Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. During the question and answer session, please press *1 on your phone. Today's conference is being recorded. If you have any objections, you may disconnect at this time. Now I'd like to turn the meeting to Dr. Henderson. You may begin.
Good afternoon, everyone. My name is Jaquiba Henderson, and I lead the state-based perinatal quality collaborative activities in the Division of Reproductive Health here at CDC. And I'd like to welcome you to our fourth presentation in the second series of webinars we are sponsoring on perinatal quality collaboratives. Today's presentation is about obstetric hemorrhage and will include a discussion of quality improvement projects and recent guidelines proposed for response to and management of obstetric hemorrhage. Our presenters today are Drs. Deborah Bingham and Judette Lewis. At the end of all the presentations, you'll have the opportunity to ask questions and participate in the discussion. A recording of this webinar will be archived on our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. Downloadable handouts are also available and may be accessed by clicking the Handout tab at the upper right side of your screen and then selecting the files to download to your computer. Our first speaker today is Dr. Deborah Bingham. Deborah Bingham is the Vice President of Research, Education, and Publications for the Association of Women's Health, Obstetric, and Neonatal Nurses, also known as AWON. She has over 30 years' experience in maternal child health nursing, a master's degree in perinatal nursing from Columbia University, and a doctorate in public health from the University of North Carolina, Chapel Hill. Most of Dr. Bingham's career has been spent working in hospital leadership positions at the front lines of health care, and she was the first executive director of the California Maternal Quality Care Collaborative, where she helped form the California Pregnancy-Associated Mortality Review Committee. She has led numerous quality improvement interdisciplinary initiatives, including launching the first California Obstetric Hemorrhage Multi-Hospital Collaborative. She has also authored many articles in peer-reviewed journals and implementation toolkits and was co-author of the California Obstetric Hemorrhage Toolkit. Dr. Bingham is currently the project director for AWON's Postpartum Hemorrhage Project. I will now turn the presentation over to Deborah Bingham.
Good afternoon or good morning, everyone, depending on where you're located in the country. It's my pleasure to be here with you today on this call and to talk with you about obstetric hemorrhage and what we can do to reduce the preventable maternal mortality and morbidity. I'm going to go over first the impact of obstetric hemorrhage on maternal morbidity and mortality, discuss strategies to improve the quality of care in response to obstetric hemorrhage, and then just use as an example of quality improvement methods that can be employed to support changes in practices. So AWON is the Association of Women's Health, Obstetric, and Neonatal Nurses, has a guiding perspective. And this cute little boy is one of my grandchildren. He's my grandson. And you know, it just reminds me that to say to everyone that this work is both personal and professional, and that everybody's family members and every one of us are connected in the United States. And so the nurses, there's over 350,000 registered nurses who take care of women and newborns in the United States. And then there's a lot of doctors and midwives and all kinds of support and ancillary staff. We're all need to work together to ensure that all women and newborns, everybody's grandchildren, everybody's children, have equal access to evidence-based, high-quality care. So that's the work that the collaboratives do, is to really try to connect what we know to be good treatments or efficacious treatments to improve outcomes. Unfortunately, in the United States, the maternal mortality ratios compared to other countries has actually has been ranked at about 47th in the world. Now, these rankings vary depending on who wrote the article, but this and which countries you include, whether you include only developed countries or underdeveloped. And there was a recent publication that actually put the U.S. as 60th in the world. So regardless of how you slice it, we do not compare well. In addition, pregnancy-related mortality in the United States has been rising if you just look at the actual rates that have been presented. Now, we know that this is a little complicated in that we know that there's better case ascertainment. We're counting better. So these data are a little, we don't want to overinterpret them. But at a minimum, maternal mortality has not gone down in the United States at a time when other countries have seen a reduction. And in addition, we know that case ascertainment does not account for the rise that we have seen. Pregnancy mortality ratio by race is also not a very happy story. In fact, it's very concerning that the African American women in the United States who give birth have 3 to 4 times are more likely to die in childbirth than women of all other races and ethnicities. And this disparity is unacceptable, and it's something that all of us need to work very hard to understand better and to make a difference and change this gap. And there has been some, when working to change disparities, we need to often, sometimes infuse more resources and more work into an area where we know there to be a disparity, and work harder to make sure that all African American women have access to what are known to be efficacious treatments. In addition, we have seen that outcomes have actually gotten worse in just even a 10-year time period. So mortality is really just the tip of the iceberg. When we compared, when Callahan and colleagues compared 1998 to 99 data compared to 2008, 2009, they found that there was a 75% increase in severe maternal complications during a hospital birth. And in addition, they found that there was also an increase of 183% in the number of women receiving a blood transfusion for delivery during a delivery hospitalization. So morbidity has also been rising during this same time period. Now, pregnancy-related deaths are related, there's several causes for them, and we know that attributing, screen went blank. Oh, dear. I don't know if you all can see my slides or not, okay, there we go, great. So this pie chart shows the leading causes of maternal mortality, and hemorrhage being one of the leading causes, and other leading causes are also listed. One of often when you talk about the sad news of higher rates of mortality and morbidity in the United States, we think about what can we do to make a difference. And so one of the things that when you read those data and when you read the reviews of maternal deaths, it has been identified by different maternal mortality review committees that there's 54 to 93% of the maternal hemorrhage-related deaths could have been prevented with improved clinical response. So this is a situation where we know what to do, but not all women are receiving what are known to be effective treatments. It is estimated that in the United States that about over 50% of all of the deaths, regardless of cause, are likely to be prevented. So this helps me be motivated, and I'm sure it's motivating many others to say we need to eliminate all preventable maternal mortality and morbidity. So as I said before, mortality is just the tip of the iceberg. So there's a lot of reasons why morbidity has gone up. And so let's dig into the hemorrhage example. So if we look at what is since we know hemorrhage to be one of the causes of maternal mortality, that is very amenable to improvements. So if we dig into that a little bit further and look at the etiology of postpartum hemorrhage, we know that uterine atony is based on coded data that 79% of postpartum hemorrhages are caused by uterine atony. So these are the studies that showed that preventable obstetric hemorrhage deaths vary from 54 to 93. So given the fact that these deaths are highly amenable or likely to have been prevented, and given the fact that 78% of the hemorrhages are caused by atony, then if we hone in on those key facts, then we can start to think about what are the best actions that we can do to make a difference. So you take those data, you take the surveillance data, you also take the etiology data that we know, and then also you look at, if you take errors, look at what's been studied around human errors, and you kind of pull that together. I came up with this summary of the generic errors modeling system and applied it to obstetric hemorrhage. So where we know that many of the deaths are likely to be preventable, and then what are the kinds of errors that are typically being made, which means that what are the solutions for reducing those type of errors. So in human errors research, we know that humans make three main types of errors. We make skill-based errors, rule-based errors, and knowledge-based errors. So what are the strategies and tactics? And these strategies and tactics are not necessarily only related to hemorrhage, but can be applied to other kinds of etiologies or causes of death. But let's stick to hemorrhage a bit more. So if we take skill-based errors, these are strong but wrong routines. And we say, well, what are the things we can do to reduce skill-based errors? One of the things that you see over and over in maternal mortality reviews are that that clinicians are denying how much blood there is, or they don't recognize it, which leads to a delay in treatment. So one of the most important interventions that we can do in order to reduce skill-based errors is to quantify, measure blood more accurately. Because if every case, people say, well, I know when they're hemorrhaging, it's just obvious, but actually, based on the mortality reviews, what happens is that recognition is coming too late in the process, and treatments are not getting to women early enough. So we aren't recognizing soon enough. Rule-based errors can be one way we can reduce rule-based errors for obstetric hemorrhage would be to have readiness plans, to have policies and procedures that people practice so that every team member knows how to respond. So we get to readiness and recognition. And then knowledge-based errors, it's interesting. Knowledge-based isn't, it's when we are in a knowledge deficit situation, meaning we don't have a rule for a particular situation. We didn't make a plan. We didn't drill on it. We don't actually know exactly what we should do. We humans like to be in, following a plan, and we will try to revert back to a plan or into a rule-based situation as soon as possible. But where did we not have a plan, and where could we have been better prepared will reduce knowledge-based errors. So having debriefs where we learn both what went well and what didn't go well will help us to reduce the time that we have a knowledge gap, and will reduce knowledge-based errors. So basically, using all of that information A1 put together our multi-year postpartum hemorrhage initiative where we are improving recognition. We're focusing in on better risk assessment on admission prior to birth and after birth. We're working with hospitals to quantify blood loss and to have ongoing blood loss measurements so there's cumulative blood loss. Improve readiness with protocols and drills, and to improve response by having team debriefs. So then the quality improvement methodology that we're using is the MAP-IT methodology. This includes mobilization, assessment, plan, implement, and track. So, and then we'll be doing many experiments to determine what worked and what did not work. If you want more information about the project, you can go to pphproject.org. So we have identified both A1 leaders who are helping lead this effort. These are employees of A1. And then we've also mobilized other, like commissioners of health in New Jersey and Georgia and council members in D.C. We've developed an interdisciplinary expert panel, hospital key informants, leaders from various sectors such as hospital associations within the states, physician leaders, a collaborative, those that are already organized some type of collaborative within their state. And so mobilizing is an important process, and one reason we like using the MAP-IT approach is often in the other quality improvement methodologies, they start with plan before it's, and so we like having the methodology where it reminds you one of the main first steps is to mobilize a lot of people. So we've mobilized also some A1 PPH project regional leaders. So these are leaders in the states or in the region that know their states and know their region well. We've also mobilized a QI expert panel, and we see, because we recognize both that it's a team approach, and so we wanted a panel that included both physicians and nurses, and physicians with different types of expertise. So we have an anesthesiologist on the panel, we have transfusion medicine specialist, we have a maternal fetal medicine specialist, in addition to nurses with expertise in different areas. So a nurse who is a manager of a hospital, a nurse who's a staff nurse but also a assistant professor at a university. And then on staff, Renee Byfold is also previously had run a safety program and had been a safety nurse at Cornell, and then also Ben, who is a biostatistician. So then the next part of MAP-IT is assess. A in MAP-IT is M for mobilize, A for assess. So the way in which we're assessing our project, and before we're totally finalizing our plan, is first we pulled in, obviously, the national data. We pulled in the errors research. And in addition, we're doing a gap analysis or a baseline assessment. And we're doing this as getting key informants from every hospital in the 3 geographic areas for every hospital. We sent this survey out and asked them to tell us how prepared they were and what were the specific areas or gaps in preparedness based on both clinical actions as well as having policies and procedures. For example, do they have access to using uterine balloons, B-length sutures, specific types of medications, hypothermia blankets. So we ask specifics around types of equipment that are available. We also ask questions on the survey around drills. Do they run drills? Do they have a standard definition of hemorrhage, and how is that defined? And also, do they have policies and procedures? So other part of our safety, part of our assessment is that we're doing a safety and cultures attitude survey in some of the hospitals. And we're also looking at, this slide actually should say staffing ratios. We're looking at both physician and nurse staffing ratios at a high level, just to see how they compare. And then other key demographic data. Then with that, that's helping inform the plan, and we're also developed quality measures to track progress. So the plan includes putting together these measures, developing an online data submission portal for patients that we can have data on the patients, and also QI sample audit data. And what tasks are completed that we feel are critical for tracking in this process, such as having an up-to-date policy and procedure. So then implementation, it's very behavior-based. What are the behavior changes we want to see at the end? So implementation is really gets down to the nuts and bolts of behaviors, and so with that we also are tracking some process measures. And these behavior changes will be different a bit at each of the hospitals. Some hospitals may already routinely do risk assessments on admission, or some may have more of a gap in that regard. And there'll be the strategies and tactics for changing behaviors will be similar across the hospitals, but will vary and be customized to a particular hospital based on their specific data. So, for each of the areas of recognition, readiness, and response, we have specific behaviors that we will be tracking. Here's an example of, we will be giving tools to the hospitals and for them to work from. And here's an example of a debrief form that we are in the process of developing that would be a way for a hospital to standardize and collect data from their debriefs when they run these mini debriefs. And debriefs we see as different from a comprehensive root cause analysis. Then the next thing in MAPID is, so we've done mobilize, assess, and plan. The next thing is to track. And how effective was the implementation? And what were the barriers and facilitators? Because we see our role as to not only help change the behaviors in those particular hospitals, but being able to articulate to others what went well, what didn't go well, and try to help share. And we love it when others share with us as well, so we learn from other collaborative efforts. So we'll be tracking the types of barriers and facilitators being described. We're going to be identifying the various strategies and tactics that are most effective for a particular hospital to overcome a particular barrier. And then we'll reevaluate and make adjustments. Another type of implementation effectiveness area that we're going to be tracking is how engaged the actual project leader are. They're going to rank themselves every month on and we call it an intensity measure. So the intensity with which they worked on the project to kind of compare implementation effectiveness to leader self-ranked intensity. So the patient outcomes that we're going to be tracking are number of deaths, number and types of blood transfusions. In particular, we're going to be looking at the number of packed red blood cells, the number of women who received 4 or more packed red blood cell units of blood per month. Peripartum hysterectomies, and this isn't all peripartum hysterectomies, these are peripartum hysterectomies that occurred during the birth admission, and then intensive care unit admissions. We recognize that not all of these measures are perfect. In particular, the intensive care unit admissions, there's a lot of variation in who meets intensive care unit admission criteria at various hospitals. but we wanted we were very excited about the work that Dr. Callahan has published and others, and wanted to have our data be able to compare to national data. And so as messy as some of these are, they're better than nothing. And I already pointed out the process measures. We'll then share the lessons we learned. We'll share them in the A1 journals, the JOG and our research journal, Nursing for Women's Health. We also are very open to submitting publications in other peer-reviewed journals as desired by the science team. And again, as we do all of this, we will continually rethink and readjust and improve on our processes as we go along. So now I've just talked a little bit about our work related to leading efforts to reduce the morbidity associated with when a woman actually would bleed. But we're also doing work to prevent obstetric hemorrhages. If you go back to the data, 78% of all of the hemorrhages are documented to be caused by uterine atony. We wanted to move a bit more upstream. How do we reduce the number of women having uterine atony? So we have a two-pronged approach. So we looked at what are the risk factors for postpartum hemorrhage. And of course, the most common risk factors are conditions that lead to uterine atony are those that render the uterus resistant to the effects of oxytocin, such as labor induction or augmentation. In addition, we know that abnormal placentation due to former cesarean birth is another area that we can also impact by reducing primary C-section rates and repeat C-section rates. So if we look at U.S. data, we see that induction rates have gone up, and actually these rates would be higher if we took out of these numbers those women who had a C-section. But regardless, they're still high, and we are also hearing about more elective inductions. So women who don't have a medical reason for an induction would be a good place to begin for reducing the number of hemorrhages due to uterine atony, and so that's where we started. We're also interested in reducing primary C-section rates because we know that those have gone up without any commensurate benefits shown to be either babies or mothers, and actually data to show that there's been some connections to more morbidities related to these higher rates of C-sections. So we have a public advocacy component and public awareness, as well as clinician awareness elements that we're working on through our Healthy Mom and Baby media, and we have magazines and an iPad magazine as well, and these are free online via the website. And part of that, we developed what we call the Go the Full 40, or Don't Rush Me, Go the Full 40 campaign. This campaign is connected to increasing spontaneous labor and also promoting breastfeeding, and again, reducing elective non-medically indicated inductions and C-sections. So there's other resources we have and other ways in which we're working to improve earlier reducing and preventing hemorrhages through other types of programs that we have. We're also partners in the National Partnership for Patient Safety, and also I serve as the Vice Chair of the Council on Patient Safety and Women's Health. And this is a multi-organization. You can see by all the logos at the bottom of the screen how more groups are coming together and joining this effort. And we're working on implementing and encouraging every hospital in the United States to begin their safety work by having 3 safety bundles in place: hemorrhage for DVT prevention and hypertension. So you can check more out on the safehealthcareforwomen.org website as well. And there's also standardized, we've all agreed on some standardized forms for reporting and tracking severe maternal morbidity and mortality reporting forms. So I'm going to now, I've gone through all the slides and just remind you if you have other, there's other resources on our postpartum hemorrhage project. There's some that are free that, for example, there's a practice brief on tips for quantifying blood loss that you can download that has the research outlined and A1's recommendations about that, and other resources. And just thank you very much for your time. And I'll turn it now over to my co-presenter.
Thank you so much, Dr. Bingham. We really appreciate your presentation. I also want to let our participants know that we will make a link available to these resources on our webpage when the presentation for this presentation is archived. I'd like to introduce our next speaker. Our next speaker is Dr. Judette Lewis. Judette Lewis is an assistant professor in the Department of Obstetrics and Gynecology in the College of Medicine and in the Department of Community and Family Health, College of Public Health at the University of South Florida. She is a subspecialist in maternal fetal medicine with clinical and research interests in maternal medical disease and the effect on maternal and neonatal morbidity. Over the past 6 years, her research has focused on obesity and obstructive sleep apnea in pregnancy, including the epidemiology of obstructive sleep apnea and its implications for maternal and neonatal morbidity. Her research in this area has also included serving as principal investigator for a sleep sub-study of the NIH-funded New Mom to Be trial and a prospective study of sleep apnea in obese women, funded by the Robert Wood Johnson Foundation Physician Faculty Scholar Program. She has also authored many articles in peer-reviewed journals regarding maternal outcomes related to obesity, sleep apnea, and HIV. Dr. Lewis is currently a clinical consultant for the Florida Perinatal Quality Collaborative and is the co-leader of the Florida Obstetric Hemorrhage Initiative, which plans to achieve improvements in maternal outcomes related to hemorrhage by implementing best practice guidelines. I'll now turn the presentation over to Judette Lewis.
Thank you, and thank you for giving us the opportunity to talk about what we're doing here in Florida and our initiative. Part of our goal here is to basically describe what the issues are related to maternal mortality and hemorrhage in the state of Florida, to review our Obstetric Hemorrhage Initiative toolkit, and to describe some of our care guidelines that we have provided to people participating in our initiative. Overall, the goals of the Obstetric Hemorrhage Initiative really mirror some of the work that was pioneered by the California Collaborative, and that we really want to try to decrease the short and long-term morbidity and the mortality related to obstetric hemorrhage here in Florida, but then also to provide maternity care providers with guidance and support so that they can implement successful evidence-based improvement programs for obstetric hemorrhage. Dr. Bingham described the overall problem related to hemorrhage, and so one of the first questions was related to how does that translate into the local area and Florida itself. One way that we were able to obtain that information was to look at the pregnancy-related mortality findings. Over the period of 1999 to 2010, this screening committee selected 756 pregnancy-associated deaths for which they investigated, and they identified that 62% of them were pregnancy-related. And in this figure here, what you see is the pregnancy-related mortality ratios, which really mirrors what Dr. Bingham said, that overall non-Hispanic blacks had the highest mortality ratio, followed by total overall in purple, and then you see the lowest are overall are among the Hispanics. And so what this told us was basically that our patterns are fitting the national trend. But then when we looked specifically at the causes of death, we saw that the top two causes of death were hypertensive disorders and hemorrhage, and that they were almost equal. When looking at the hemorrhage deaths even more closely by cause, up to a third of them were ectopic pregnancies, but the rest truly would be in the hand of obstetric providers. In other words, crossing labor and delivery, or in the antenatal period with obstetricians. So these are situations in which we can potentially make a difference. The other question became, when do these women die? And you see in this figure that 42% of them will die even before delivery, and then the rest of them at some point in the immediate days after delivery, and very few are far out. So again, for most of these women, when they're dying, they're intersecting with the healthcare system. They're there in our operating rooms on our labor and deliveries, and so we have an opportunity to make a difference. Before starting the initiative, the other question that came up was basically who should be involved in this initiative, where are they dying? And what you see in this figure is that 60% or more of the deaths actually occur in the large hospitals. So yes, there is risk related to the smaller hospitals, but truly they're dying in the hands of the larger hospitals, in part because of transfer patterns and related to risks for these women. So as I stated, we followed the lead of California, and when we started the planning of this initiative, we decided that we wanted to invite an alpha cohort of hospitals to participate in the initiative, and we were met by overwhelming response. In the end, we ended up having more hospitals participate than we had originally planned, because we had a hard time saying no when you're met with enthusiasm. And so we currently have 31 Florida hospitals, and that actually North Carolina, some of the hospitals there had asked to join our initiative. And so we said yes. The initial timeline that we set for our collaborative is listed here. It was a very aggressive timeline, and that in part that was on purpose so that we can really just get things done and get them done quickly. And we have stayed true to the timeline for the most part, with the exception of right now we should have been at the mid-project in-person meeting for the alpha cohort, and that has been pushed back some to the fall, so that instead of it really being a shorter initiative, we have extended it a little bit, but not by much. And certainly, as I stated, we've met all of the other timelines, so that has been great on our part. These are some pictures from our initial kickoff to the project, and what you see here are some of the key elements that we stated should be part of any hemorrhage initiative at any hospital and part of the protocols. And so I'll go through some of these as we progress into discussing the toolkit, but it provided us with an opportunity to meet with the representatives from these individual hospitals in person. And what we did was that we not only went through the initiative and the suggested protocols in person, but that we also gave them examples regarding how to do things, how to conduct simulations, and this is the picture down here where we actually conducted some simulations, how to teach quantitative blood loss measurements, so that they can see in person some of these concepts in play and hopefully see how easy they were. So for our toolkit, we had the goal of providing the hospitals with a resource. And it was very important for them to understand that it's not we're not saying this is standard of care, because there was concern regarding some of the legal ramifications of participation and would this toolkit be viewed as standard of care, and we're saying no, it's not. Rather, it's a resource and it's a guide, and that individual hospitals should use this guide so that they can create their own products and their own protocols that will match their local resources so that they can achieve the goals that we're trying to achieve. And so to go through some of these key components, one of the major components, we said, well, what we want is that for the individual hospitals to improve their readiness, so that if they have a hemorrhage, what do they need in place? And that it would include such things like having a hemorrhage cart, which has all of the key components to managing a hemorrhage all in one place, having instructions and protocols, partnering with their blood banks, conducting regular drills, making sure medications are available and that they have resources for special cases, and of course, education is always an important part of any protocol that you have. In addition, we wanted there to be an emphasis on learning, and one of the most effective ways to learn is that you can have debriefings or huddles after there's been an event, but then also establishing that culture where it's expected that that will happen and that there are no punitive ramifications to having the debriefing, and that no one feels like they're being attacked. And that all cases, all serious cases should be reviewed for any kind of systems issues that can be improved. We also wanted there to be an improvement in the recognition of a hemorrhage. And believe it or not, that has been one of the major components that has been recognized over time, that there's a delay in management and treatment because by the time you recognize that there's a hemorrhage, the patient may already be in a stage 2 or stage 3 hemorrhage, and so we want to prevent that. And so we were advocating having ongoing assessment of hemorrhage risk that starts in the antenatal period in the doctor's office, and that it continues on through the postpartum period, and educating the providers to understand what are the early signs of hemorrhage and how do you recognize them and use those signs and symptoms in order to prevent any further hemorrhage, and also using quantitative cumulative blood loss assessment, not just at one point in time. As I stated before, denial and delay are major parts of why there's a lack of response. But then there's also the issue of not being familiar with these circumstances because, for the most part, these severe hemorrhages tend to be uncommon occurrences. And then there are also other barriers such as insufficient communication and just providers not effectively using blood products. And we also wanted there to be improved reporting of OB hemorrhage by using standard definitions and consistency in their reporting. So we tasked the participating hospitals with these key elements. We told them that the goal was for them to develop their hemorrhage protocol, develop a massive transfusion protocol, start antepartum risk assessment, use active management of the third stage of labor, quantify blood loss, construct an OB hemorrhage cart, ensure availability of medications and equipment, perform interdisciplinary hemorrhage drills, and debrief after OB hemorrhage events. We left it up to them how they conducted each of those pieces. There were certain minimum guidelines in place, and we provided them with guidance, with examples, and also we conduct seminars and webinars so that different hospitals can share their experiences. So in terms of developing the hemorrhage protocol, why everyone knows protocols have been demonstrated to be associated with more safety because they provide a guideline for which you can use to manage situations for which are uncommon or even routine situations. It really eliminates some of the variation in a situation, and so it improves safety. We do know a lot of the worst case scenarios tend to happen at night or on weekends or even when it's not the usual team, when there's a float nurse on, et cetera. And so a protocol really helps the person or the people involved to know what are the steps that are expected. These protocols need to be effective and written so that there, again, is no fluctuation in what is expected, but that also that every provider can use it, whether they are physicians or nurses, anesthesiologists, that they have this common format of communication, and that it helps them to have a rapid response to an emergency. In many of the cases, we're using pre-written orders that can be instantly executed. So once you say initiate the hemorrhage protocol, all of those orders are already there, and there's no need to stop the response to a hemorrhage to ask for an order for a certain medication. And also, these protocols will also demonstrate an escalation through various stages of hemorrhage, because the orders you may need for a stage 1 hemorrhage will be different from stage 2, stage 3, et cetera. The massive transfusion protocol was one that presented some more difficulty for the hospitals simply because this was now no longer just a labor and delivery thing, but rather you had to depend on the blood bank to be cooperative and to create a hemorrhage protocol. Some of the hospitals had an OB hemorrhage protocol, an OB massive transfusion protocol in place already. Others did not, and so that required some work. And part of the reason that we really emphasize this, just as in the California toolkit, that basically we recognize that whole blood is very good for OB hemorrhage, and so you want to keep your resuscitation as close to whole blood as possible. And but then as you're escalating through the stages, you want to keep in mind other things such as needing to treat DIC if it happens, and keep in mind the supportive measures because as you're massively transfusing, you can develop a metabolic acidosis. And some people forget those components. And so part of having the massive transfusion protocol will allow you to get large volumes of blood products to labor and delivery and quickly. And anyone who's been involved in a hemorrhage knows that one of the important pieces is not just the blood bank being prepared, but also labor and delivery being prepared so that they know how will they get that blood transported back and forth in the most efficient manner. Antepartum risk assessment was new for a lot of people. Certainly we've noticed at our center that there is a lot more proactive management of antepartum anemia, whether it's through prescribing iron or even recognizing those people that are not responding to oral therapy and using IV therapy of iron. But it's just the recognition that these are the people who are at risk, and what are the things that we need to do for them before they get to labor and delivery so we can optimize them. And if it's something that we cannot optimize, we need to be prepared on L&D for these high-risk individuals. This is just one example of an ongoing hemorrhage risk assessment where they list antepartum and intrapartum factors. And so you may take someone who started off as a low risk because they had no known bleeding disorders, no postpartum hemorrhage, et cetera, but then they come into labor and they develop chorioamnionitis, and so it's recognizing now they have moved to medium risk and that there are some different things we need to do for them. Active management of the third stage labor, again, was met with some difficulty because different hospitals had their own ways of doing things. One thing that is widely accepted in the studies is that oxytocin does decrease hemorrhage in the third stage of labor. There was just controversy about when to give it and what else to do along with it. We left it at oxytocin along with a vigorous bundle massage with delivery of the neonate, and that each site can determine on their own at what point they wanted to administer it because there was nothing consistent in the literature to guide that. Quantification of blood loss has also been met with some difficulty. And when I say these things are met with difficulty, you should know that overall, though, we are making great strides, and that when we look at the absolute numbers in the reporting, people are doing better and they're increasing their use of these tools, but that they, some of the hospitals did need to get creative to get their providers engaged. And this was one of the biggest areas where we had difficulty in that a lot of the operating physicians felt that they should be estimating blood loss and took offense to having someone else tell them what the blood loss is based on quantitative measuring. But we know it's absolutely crucial because as the studies show, there can be as much as 50% underestimation of blood loss. And that's the problem. It's usually underestimation, not overestimation, so that by the time you recognize that you've lost too much blood, the patient is in an advanced stage of hemorrhage. So we use different tools to achieve that, including weighing, various pads and chucks. We provide them with posters so that they can just look at a poster as a reference. So if they see how much saturation there is of the chucks or the pad, that can help them. But then also the poster's telling them that if you weigh it, how do you convert that, the weight into grams. A lot of the hospitals have moved to using graduated collection containers, such as different drapes for vaginal deliveries, where you can actually collect some of the blood. Of course, there's a difficulty of estimating how much of that is amniotic fluid, and so we've addressed some of that by having them look at the amount in the drape, the collection area, and then after the baby is delivered, look again, and you can estimate that that was amniotic fluid, because that's usually when you get the big gush is after the baby comes out. And so that was just one challenge, but a lot of the hospitals are finding that the cost difference between their usual drape that they use for delivery versus the one with these graduated containers is very minimal, and in some cases they're equal. This was what I was talking about, the saturation of the various pads and chucks. Again, posters that you can have around so that it can help the providers to estimate how much blood there really is on the chucks. So other ways that you can teach them, other than the posters, is to actually have them do a group activity where they're weighing groups of pads and doing them together. And so what we found when we did this was that the learning curve is actually not that great. And so that after they've done a few, they become better at estimating what the amount of blood loss was. And again, some of these calibrated drapes that we talked about. There are still some unknowns, such as intra-abdominal bleeding, and how do we estimate that. Again, from our standpoint, we really encourage all of the sites to go to a process of quantitative blood loss, and it's been supported by many other organizations, including ACOG and AWAN. And we leave it up to them, the precise methods that they use, but we've given them those suggestions. There is also controversy about who should do it. Should it be anesthesia? Well, they're at the head of the table. Should it be the OB providers? They're not always looking at everything. The nurses, but they will say they're busy. And so really it should be collaborative. And what we've had in the past at some centers is basically that at the end of the case, anesthesia may list what's in the canister near them. The nurse may quantitate the laps, and the OB provider will, look under the drapes to make sure there isn't blood on the table or running down the floor. And so collaboratively, they can come up with the quantitative amount of blood loss. Hemorrhage cart just simply has all of the tools that you would need. We encourage each site to locally ask their providers what the cart should consist of, but we gave some samples, and not just ask their providers, but construct a cart and then run through a drill and see whether the cart was adequate or not, and then you can make adjustments based on that. The same for medications and equipment. we made some suggestions of which medications you should have nearby and readily available to manage a hemorrhage. Performing drills is a very, very important part of any initiative, because we know when it comes to learning that there is more retention when there's a drill or a hands-on activity such as a simulation than there is for when you do a lecture. Drills will also help you to test this system that you've put in place and see whether or not it truly works. So we advocated that each hospital should run drills and they should do it at different times of day, which makes sense. Hemorrhages happen at any time of day, and in particularly you can find at night that some of the systems that are efficient during the day may not be efficient at night. And so by running drills during those times, you do find out that that you may change some of your operations. You may need to change some of your orders, etc. We also feel that all members of the healthcare team should participate, and that includes the anesthesiologists, nurses, physicians, ancillary staff, because you need to try to make this as close to real life as possible so that you can identify any system gaps, and that there should be a debriefing that occurs after every drill and also after every OB emergency, again, so you can identify the places that you can make a difference. And debriefing does many things. Other than helping you focus on areas for improvement, it allows you to give immediate feedback to someone, and then it does provide an emotional decompressing for individuals, particularly after a true OB emergency. And so we find it to be a very effective tool. It will increase the engagement of all of the providers and then also improve the confidence of the staff when it comes to dealing with a similar emergency. It doesn't matter who leads the debriefing. It can be an RN, it can be an MD, but there are certain components that should be in it. When you debrief, often they advocate starting with what things worked so that you can reinforce some of those positive aspects of their response, and then keep it open-ended and discuss what didn't work. And what can be done differently. Dr. Bingham showed a demonstration of a sample debriefing form earlier. We provide some examples on our website too. Another major component of our initiative is basically having providers recognize that hemorrhage doesn't just happen, but rather it happens in stages, and that your response should be based on the stages. One of the key things that really made people focus on this is this recognition that when you looked at data regarding maternal deaths, that approximately 85% of them had abnormal vital signs for 12 hours before they died. And part of the problem was that people were not identifying those abnormal vital signs as a trigger to do something. And so we were advocating for the hospitals and the providers to recognize that the vital signs are important, do not ignore them, and actually in some cases that may be the only thing that you have to clue you in that the patient is hemorrhaging until you actually see the hemorrhage. And so as part of their protocols that they should be including specific vital sign and blood loss triggers, and that there are specific thresholds for them to call in for more staffing and help because they are starting to either hemorrhage or to have an escalation in the severity of their hemorrhage. And here they're just listed. Again, they're listed on the various websites. Here, this is an example of the California OB hemorrhage guidelines, where they actually provide a summary of the various stages in a table format, but they also have a flow sheet. And our providers felt like the flow sheet was very helpful for a real-life situation where you're having a hemorrhage, where you can quickly look at it and determine what stage are you at, and what are the actions that should take place for various stages. And so we, in fact, did come up with our own where we changed some things around, and we provided the various hospitals with laminated copies of this algorithm. And I won't go through them in detail, but again, this is just each stage enlarged so that we can read it. And what you see is that what we do at every stage, we talk about basically, what are the things that you're supposed to be doing? Who should you be notifying? What are the orders that should be carried out, including addressing medication and even some exceptions, what vital signs you should be looking for, et cetera, and, what are the next steps. And so we recognize there's a stage 1, and that if you have continued hemorrhage or various vital signs, that you then escalate the patient to stage 2, where you become more proactive, or you start transfusing with, again, the thought that you are trying to manage the problem a little bit more aggressively before it becomes worse. They can escalate to stage 3, and another thing that we emphasized back in the earlier stages was having providers, consider some of the surgical options earlier. One of the key things we found was really a delay in people going to the operating room, and that so we really emphasize that, okay, as you're escalating, you need to recognize that and recognize that the best place may not be the labor and delivery room, but rather the operating room, so that you can start doing some of these surgical interventions in order to stop the hemorrhage, and not wait until you're at a stage 3 where you're giving massive transfusion protocol numbers of units of blood, and then that's just when you're considering these surgical options to stop things, because at that point you're already at significant hemorrhage, and that you're likely heading to the intensive care unit. So overall, our objective and the things that we are measuring really are related to, not to maternal death, because that's such an uncommon event, but rather we wanted to look at some of the severe morbidities that then approximately lead to death. And in doing this, we also said, well, how can we lower the morbidity and the mortality of OB hemorrhage? And without a doubt, we recognize that part of it is lowering some of these things that make you medium to high risk. So, reducing the cesarean birth rate, both primary and repeat, reducing things like chorioamnionitis, multiple gestations, long inductions of labor, long second stages. And so if we lower the incidence, then the incidence of hemorrhage, then that helps us meet our goal. But then also, when we have hemorrhage, then we definitely need to respond more quickly, so that we can keep a small hemorrhage from evolving into a massive hemorrhage, and to use all of these techniques and tools in a well-organized and well-executed, timely fashion. When we started the protocol, we did have the hospitals that were participating fill out sort of a baseline survey, and I went through all these components of the toolkit, and when we saw their responses, this was basically what we saw, that a lot of hospitals were already doing drills, but what we found when you delve a little bit deeper, though, were the drills were not consistent, or they may have just been at one point in time. We found that a third did not have access to all of the surgical procedure options. A third did not have a hemorrhage protocol. A third did not have a massive transfusion protocol. And almost half did not quantify blood loss for both vaginal and cesarean deliveries, and 60% did not debrief after events. So certainly there were areas for improvement, and as we're getting some of the reporting data coming back, we're seeing all of these numbers improve. So, again, just to emphasize, the best practices to improve outcome in these cases will be to have the hospitals develop a general and a massive obstetric hemorrhage protocol, to perform interdisciplinary simulation drills and to debrief afterwards, and perform a quantification of blood loss. Thank you, and I'll take any questions or comments.
Thank you so much, Dr. Lewis. That was an excellent presentation. At this time, I'd like to let the operator know that we are ready for questions.
Thank you. We'll begin the question and answer session. If you'd like to ask a question, please press *1. Please unmute your phone and record your name clearly. I'll introduce you by name. And to withdraw your request, you can press *2. We'll wait just a moment for questions. Again, that is *1.
This is Dr. Henderson. While we're waiting for questions, I have a quick question for Dr. Lewis. I think it's exciting, the work that you all are doing to help reduce obstetric hemorrhage, and I was particularly interested in the other steps that you're looking at, the things that put patients at higher risk for having a hemorrhage. And I thought it was interesting that you listed reducing long second stages of labor. And I'm curious to know what you propose to do that when you're also wanting to reduce C-sections.
That's a very loaded question, right?
Yes.
and a controversial one, because you can argue that we almost can't, that the two are sort of opposing goals, unless if you employ more midwifery techniques, that may help with that second stage of labor. And so I think, the first part is recognizing who are the people who are at most risk for a prolonged second stage. The second thing, and so that, recognizing ahead of time, is this, a 10-pound baby that may not fit. The second thing is also, if you decrease inductions of labor, or if you wait to keep that patient, you wait until they're truly in active labor, rather than, they're in latent labor and you keep them in the hospital and they end up with oxytocin, that will decrease the second stage of labor. But then, then other than that, those are the only interventions that you have.
Mm-hmm, mm-hmm. Thank you. I believe we have some questions waiting.
Yes. Our first one comes from Jocelyn Davis. You may ask your question.
Hi. So my question is really somewhat related to the other question that was asked. I was going to ask you how you reduce long inductions of labor. And also related to that last question is, have you seen any evidence that there's a difference between a patient who labors down, which is the only way I know to shorten the active pushing phase, versus, so labor down, push a shorter amount of time versus pushing for a long time, if that makes a difference in the risk for hemorrhage?
So, going back to the first, I forgot the first part of your question already.
How do you reduce long inductions of labor?
Okay, and so one of the things that, from a policy standpoint, that really has worked is if the hospitals employ a hard stop, where before you induce someone, you really have to have a good reason to induce them. And that has pretty consistently shown to work. The other thing that has been demonstrated to work is that if you have, from a policy standpoint, if you have people that are engaging in sort of public service announcements to, say to patients, don't get induced just for the heck of it or just for convenience, because there are ramifications. We find that again, advocacy works when it comes to things like this, but we need people to push it. So if you're just at your local hospital, you're stuck with just hoping that your department, and really helping encourage them to have a hard stop process in place. Physicians don't like it. But, I didn't like it in the beginning, but I have come around to really liking it because it does, we do have a form that we have to fill out to induce anyone, and we have to justify why we're inducing them. And so it really gives you, for the patient who's pushing you and they have no good reason, it gives you an out. For the patient who really needs it, such as your chronic hypertensives or any high-risk person, well, then you're really stuck and you kind of don't have, you don't have an alternative. But I think if we can decrease the unnecessary ones, then we'll be making great strides. Now, as far as laboring down, I happen to be a big fan of it, so you've reached the right person. There isn't data consistently to say that, yes, it makes a difference. But I think certainly for the nulliparous patient, that if the tracing is fine, that I think it is a good technique. You don't have to rush and intervene as soon as they're complete. If the baby looks fine, you give them time and they are able to decrease that second stage.
Thank you. This is Deborah Bingham. I'll just add also in addition how ready they were or their Bishop score, and that's one of the strategies that a lot of hospitals have been using in the country is making sure that women with a Bishop score more than 8 or, is in place before they begin an induction, and in addition to all the other things that Dr. Lewis mentioned.
And I can certainly share, if you're interested, the sheet that we use that I think makes the providers fill out, because Dr. Bingham is right that one of the components on there, if it's a medically indicated induction of labor, we don't have to fill out anything. If it is elective, we have to fill out the Bishop score.
Thank you. It would be great to have that form.
Sure, I can get that.
There's also, I don't know if you've seen the recent publications by Spong and then also the recent release of the joint ACOG SMFM document on this very topic, which also has some other important information that might be useful to those on the call.
Yeah.
Are we ready for the next question?
Sure.
Okay, we have Deborah King. Your line is open.
I was wondering if it would be possible to receive a printable copy of the slides.
Hello, I can answer that question for you. This is Dr. Henderson. Actually, the handouts for the presentation, including the slides, is available on the web page for the presentation, on the live meeting web page. If you go to the very top of your screen on the right-hand side, there's an icon that looks like 3 white pages. If you click on that icon, you will see the 2 presentations there. You select them and then click download, and you will download the presentations that can be printed out from your computer.
Thank you so much.
You're welcome.
Thank you. Our next question comes from Nanny Mays. Your line is open.
Yes, hello. I'm hearing some of my colleagues. I'm transfusion medicine. My husband is obstetrical anesthesiologist, so I come at it from both ends. One of the questions, it was very interesting looking at the high risk for obstetrical hemorrhage, because some of them can also go into some other issues. Hypertension, low platelets, and anemia can also be associated with another one of the most common causes I've seen of perinatal or antenatal death and morbidity and mortality, which is also TTP. So do you also address some of those issues as well?
Absolutely. Do you mean, were you talking about the table that classified people as high risk or low risk?
Yes, absolutely.
That was just one example, and actually in the end, the list that we ended up coming with was even more comprehensive and had a lot more conditions on there. And the hospitals laughed and said, well, basically everyone who walks through our door is medium to high risk. So yes, it was not a comprehensive list.
Yeah.
And there's a list also in the CMQCC toolkit. You can go into that toolkit, and that, and I'm forgetting the name of the author, the researcher who studied that table. I can say when we built the table for the CMQCC, we did it based on expert opinion. There wasn't any research on how to stratify those risk categories. And since then, there has been at least one paper published that looked at how accurate that, or how helpful that that kind of risk categorization, how that linked to outcomes, and found it to be very consistent. And then, as I mentioned, for the work we're now doing in Georgia and New Jersey and DC for the A1 Postpartum Hemorrhage Project, we are adding 2 more risk assessment touch points. One is prior to the woman giving birth, and then the second additional one is immediately after giving birth. And with that, we've developed so it's basically encouraging an ongoing risk assessment. And Brian Bateman, who's published a lot on the epidemiology of postpartum hemorrhage in the United States, who is one of the members of our expert panel, has recently published a study on showing that history of hemorrhage, family history, is one of the things that needs to be added to the risk assessment table. And I know CMQCC is in the process of updating their toolkit, and I personally haven't seen how they're adjusting that. I know for the A1 risk assessment table that we're recommending will include family history of postpartum hemorrhage, and then things like whether the woman had induction or augmentation. So those are all important. Yeah, go ahead.
Yeah, and I would also say that I agree with that very strongly because of the fact that my husband recently dealt with a case. Of course, it's always the middle of the night, and it turned out she was bleeding, and they couldn't figure out why. And he called me to get a consult, and it turned out that there was a family history of bleeding, not just postpartum, but just bleeding, and she did have von Willebrand's disease.
Right.
And so I would agree with you. I think family history. And he also had another case where he was going in to do a tubal ligation, listened to her chest, and she had grade 4 aortic stenosis. So I think sometimes the patients do come in with incomplete medical histories, and it falls on the team that's actually doing the delivery to get some of the information that may not be apparent.
Yeah, I think those are really good case examples of why, and in addition, doing really thorough admission history and risk assessment. And then we also have, we know that then there are things that happen, such as prolonged second stage, such as induction, augmentation, such as infection, chorioamnitis, or other conditions that occur later in the, during labor that need to be taken accounted for. And so we're going to be recommending some very specific actions, like who needs to be called and notified that we have a woman who is now high risk for hemorrhage, and basically a mini timeout for every birth prior to them giving birth, that there's this quick, brief risk assessment, and everybody, she's high risk for hemorrhage because of this reason. And that's to be done before birth and then after. But if you haven't, and then it's true, like if the person who did the risk assessment on admission didn't do a very thorough job, clearly that needs to be reassessed. You may have had handoffs, and people may have not documented, so you need to really ask those history questions even throughout. So it's a really, really good point.
Are you guys available for consult if you start setting these up? I could tell why all your hospitals were enthusiastic. I'm like ready to throw my hands up in the air.
Well, as actually the Florida, I regularly talk with the Florida nursing leaders. We email back and forth all the time, and we share. So, so at this point we we try to be as helpful as we can. That's why I wanted you to have our website, and because we wanted this shared throughout the country. We won't be able to do intensive mentoring for any hospitals, but we hope that this program will grow. We see this more as a pilot. At least that's A1's thought, is that this is a pilot, and we would then continue doing this type of work with other hospitals because we recognize we're only in a few states, and Florida's done a lot of work, but there's a lot of states that aren't covered by the California, Florida. I know Oklahoma's doing something, Illinois is doing something, New York's doing something, but there's still a lot of gaps in the country that still need to be covered. So
when you look at the international statistics, United States is pretty low on the scale for this type of issue.
Oh, yeah,
So.
yeah. We definitely can learn. So what state are you all in?
Well, I cover Virginia, North Carolina, and West Virginia.
Okay, yeah. So those are states that I don't know of anything going on in at the moment. So.
No.
Like I said, we have a few of the North Carolina hospitals that are part of our initiative. And we also have our toolkits and everything on our website. You know, I'm a big fan of Google. You just Google Florida Perinatal Collaborative. And what we did was that, you know, to go back to some of those lists, so what we did was basically we looked at the California toolkit and we looked at all of the literature, you know, since that toolkit had come out and tried to update it. And periodically controversial things will come up and we'll review the literature and update the website. So there are certainly resources that if you wanted to start locally, you know, within your hospital to make some changes, the resources are there to help you. You know, it just may be more difficult for you to start up on your own.
Yeah. Oh, thank you. Thank you. Wonderful presentations.
Thank you.
Thank you. And before we ask our last question, if anyone else has a question, please press *1 now. Okay, I'm sure our next question is Linda DeMille. Your line is open.
Hi. I had a question regarding what I've noticed. I'm up in Massachusetts and Boston, and what I've noticed just in practice is that it seems that magnesium continues to run even as we advance from stages into the hemorrhage process, and I wondered if there's any thoughts on that, whether that should be something that we do have a lot of high risk, and we have a lot of people on magnesium sulfate running it, you know, between 2 and 3 grams an hour. I wondered if there's any information on that or recommendations regarding that.
This is Deborah Bingham. I do not know of any. We did not address that previously in California. But we didn't encourage them to stop. You know, that we did not say to stop magnesium for women who really are at risk for seizing. We do know that they're at high risk for bleeding, so they may need more oxytocin. We also recognize, and it's kind of a little off your question, then I'll let Dr. Lewis answer your direct question, but frankly, it's almost like, you know, if you pull up a rock, you'll see all the ants under it. The more you dig into the topic of obstetric hemorrhage, you realize all the more you don't know about it. And so
that's true.
One of the other things that we realize that is completely, it's related to your point, is there are very poor data on how much oxytocin to give postpartum and how to administer. And so we put together, it's not out yet, but it will be open access soon, about recommendations for IV administration of oxytocin for women with IVs and how long, what's the dilution, what's the rate, and how long those should run. Because currently that's all over the place in the country. So, yeah, you raised a very important point, and I honestly don't. I mean, I think most people are practicing that they leave the mag sulfate on. But, Dr. Lewis, what's your answer? I'm very interested.
So I individualize it. And so, you know, the reality of it is, you're right, that during a hemorrhage, everyone is so focused on the hemorrhage, a lot of people do not stop the magnesium. But one of the things you should keep in mind is that there are newer recommendations from the Society of Maternal Fetal Medicine and ACOG about management of hypertension in pregnancy, and that actually they've sort of relaxed who gets magnesium for preeclampsia, and that if you have a mild preeclamptic who may not have neurological symptoms, you may not necessarily need to give them magnesium, according to those recommendations. But I do individualize it because there are no data, and we just know physiologically, though, that there is some uterine relaxation with magnesium, and so I err on the side of stopping it for most patients, unless they have seized. If they're an eclamptic, you know, again, then you're looking to make sure that this isn't DIC that's causing it, and that, in which case, that's what you need to fix.
Yeah, I agree. I think that it has to be individualized, but it's an important part of just making, as you say, when things get hectic in the room and you're trying to manage the following policies, it's amazing how that mag just continues to run. And as I said, I think it is when it escalates to a certain point, it definitely needs to be one of those debrief kind of things, like should we have shut that down? Would that have been helpful?
Right.
Sometimes it seems to make a difference sometimes. But I appreciate everything that you guys are doing, and hopefully Massachusetts will be joining this. We do have a small contingency together looking at this through the Mass Perinatal Quality. So again, applause to you all, and thank you so much.
Thank you so much. This is Dr. Henderson again. We have a few minutes left. I think we can take one or two more questions depending on how quick we can respond to them. Next question, please.
Question comes from Jen Rayford. Your line is open.
Yes, I just have a question. If you guys have found correlation to hemorrhage due to high or low dose Pitocin?
There's one study I know of that looked at the, and again, I'm sorry I don't have the name of the author front of mind, but that looked at the dose relationship between oxytocin and uterine atony. I don't know, Dr. Lewis, are you familiar that there's definitely receptor overload, and the more oxytocin someone had received, that they will have higher risk of hemorrhage, and the longer the induction, the more risk. So what about?
Yes.
Yeah.
So I agree with you that I think we've read the same data. So if you do a search for it, that data exists, so that it's well recognized that prolonged oxytocin use is a risk factor. And I remember that when I first read it, I think maybe a year or two ago, in my mind, I jokingly said, wow, the war on oxytocin. It seemed like it came all of a sudden and it's everywhere. But I have to agree that once you start reading the papers, that there seems to be a clear relationship.
Now, what are your thoughts on the 6x6 Pitocin?
What do you mean by 6x6?
Starting your inductions at 6 and increasing by 6 half hours.
Well, I mean, I don't think there are guidelines from that standpoint, right? Because this is where you get into some of the difficulties. And on the one hand, you think prolonged oxytocin, may increase hemorrhage risks. But, I don't know that jumping so aggressively helps to solve that problem. I think it all really goes back to how about we just admit people who are in labor and not, in true active labor, not these latent laborers, who are, uncomfortable, and so they really want to stay, et cetera. So I think that's part of, we have to be more aggressive about being upfront, saying, let's not intervene until they're really in active labor.
And I'll just add real quickly, there is a Cochrane review about physiologic labor, comparing physiologic oxytocin to other methods of administering oxytocin, and showing that ultimately the outcomes seem to be pretty consistent. And so I know many women prefer the physiologic approach. So there's many considerations besides just hemorrhage and how you determine the dosing.
Yeah, I was just more worried for your medical inductions, versus someone who goes naturally. We have a couple physicians that, with their MAG patients, still want us to do the 6x6, and I didn't know if, what it was as far as hemorrhage, how that works. So.
Good question. I don't know.
Yes, those were all great questions. This is Dr. Henderson. I have to apologize, but we will have to end our question and answer period at this time. I'd also like to take this time to thank Drs. Bingham and Lewis for giving us excellent presentations of quality improvement efforts to address obstetric hemorrhage. We'd also like to thank all of you for participating in this webinar and invite you to provide feedback about this presentation and this webinar series as a whole. We'll be contacting you after this webinar for your input. We hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. We encourage you to visit our webpage at www.cdc.gov www.gov/reproductive-health/maternal-infant-health/PQC to learn more about CDC support of perinatal quality improvement collaboratives. You can also contact us if you have any questions at the DRH info link at the bottom of our webpage. Thank you again, and everyone have a nice afternoon. I'd like to ask the speakers to remain on hold.
Thank you. Thank you all for attending today's conference. Everyone else may disconnect now. Thank you.